I'd written a paper, which I think with Dave Myers from, and we'd originally talked about, I was going to present that in this time block, and then thought it made more sense for me to summarize some of those themes, and then on the examples we use in that document, some of them include, they either include or they're well represented by the panel here. So we thought it made more sense to have the speakers speak. And we've done this, actually a number of the group up here were together at Chicago on a panel, and I was in Florida with Kevin and a group, Miami-Dade, that Kevin put together recently. So that's how we want to do it. We want to come at this question from the point of view of where is this marketplace right now, somewhat in the context of the stimulus, but in my talk in the beginning, I'm going to go a little bit more to, at this point in time, what is the opportunity in the crisis, and how might that unfold? We're then going to have examples from the experience of the panel, from the state health perspective with Jim Figge, from the Miami-Dade and National Medical Home Strategy, from the work Roger has done in Governor Manchin's state and in his vast experience in facilitating strategies at the interface of commercial and public sector health, and now health towards human services. And then finally with Cheryl, in terms of Cheryl, which is, you all know Cheryl's background and the wealth of the work she did and the benefit of it from a national level, and now she's in the foundation or the private sector as well. So I'm going to go to three themes. I'm going to move fast. The first is trends towards connected systems of care. So this is a theme I want to get at, and it kind of goes to the professor's point yesterday. We had a lot of momentum or innovation start to occur in the last decade on this question of innovation. And in the past conferences here, we've gone through a lot of that. But we should really understand the implications of last year in terms of tipping point. Because what the governor talked about, you can't, from a political perspective, you can't waste a crisis. Well, this is a crisis. So we're going to talk for a minute on that, and then what does that portend in terms of innovation? And I've framed in the paper, we framed it in the same time frames that the meaningful use discussion occurs for the next 5 years. Won't go into this other than it just shows you that Daniel's used this in the past, I know in his papers. I at one point chaired for about 3 years the healthcare task force in Massachusetts when I was the Secretary of Health, putting together the strategy that you would need to get together to get to health reform. So we worked on that for a number of years. This was one of the pieces that we put on a blackboard with the commercial marketplace on health, human services, and everybody else saying, well, wait a minute, let's get consumer-centric and understand the systems that this single person or child touch. And in a way, that's the challenge that we've been talking about the last few years. And when we talk about we had disconnected systems of care, and much of the discussion in the last few days has been on this. So you have multiple programs serving the same consumers. We had a history of categorical funding, enabling legislation, separate licensing strategies, IT systems a decade ago that couldn't talk to each other. So they were an impediment to integration because they weren't built in a way at that point in time to talk to each other. And then we saw this trend towards connectivity, part of it being an increasing public demand. Katrina was an example, as was 9/11. And then you had the work that CMS has done, and Rick and others. The CMS, the MIDA architecture, I think, is a pretty significant discussion that it exists. And they began that discussion of a service-oriented architecture at a time when the business model wasn't that. Now it's lucky that we have that thinking in place because there's a framework, and as Rick Howard and others will be talking about the variations of where does this go next, but that concept of let's have some pilots and models, including the Medicaid transformation grants. And you had the last president as well talking about creating OnShit and HIE themes. So we had some models starting to occur. And then in the technology world, you had advancements in technology that allowed systems to communicate, which was giant. I mean, it's giant because you could have these large old systems that now you could come up with strategies to figure out how can you connect across them. I'm not going to go into this much other than to say this. If you look at the top level, where those boxes on the top, those are the different health and human service agencies that used to be disconnected by legacy. If you look at MIDA or if you look at the commercial marketplace, this is kind of an architecture of where things are moving right now. So at the top, you had those disconnected legacies, but now you have what says Connected Service Hub. You have the capacity technologically to connect to those legacies and pull information and integrate it. So now we're starting to see the development in that middle level of shared services, of functions that used to be created for every single agency separately. Now you can begin to create them and share them. So when CMS is looking at data warehousing, or when Jim Figge will talk later about data aggregation or data warehousing and the value of the information in one agency, the question becomes, we can now translate that and share that with other systems. So technology has moved in a direction, whereas people have said, it's not the inhibitor at the moment. It goes back to, so how do we get to the business strategies to intersect systems and services? So that was the last decade. Now, the last year. I went through all 50 governors' State of the State addresses last year, the week of the National Governors Association winter meeting, the prior week. And that's where I met Governor Manchin and a number of other governors. We just were talking about the market. What the hell's going to happen here right now? Their messages were framed heavily. We're in a crisis, emergency, incapacitated. Just as the governor did, they pretty clearly forewarned this is at least 2 to 3 year budget problem, no matter what. If it turns positively tomorrow, we got a 3-year budget crisis on the state level. And that's because of the nature of the way states are financed. And that health crisis, in addition to the financial crisis, health care was a crisis contributing to it. So you had the 2009 health spending at 18%. It had grown by 18% since 2003. Medicaid was growing at 8% a year. You had 46 million people uninsured. The gentleman, the doctor from ONC yesterday hit it right on the head, from my view, on this question of we can't assume that we have safety or that we can measure the outcomes. We're not there. But we have a real need for it and a demand for it and a clear mission coming out of ONC and the federal government right now that says we've got to get to that. But so you got a financial crisis and you got a healthcare crisis that are morphed. Now, the one point that I'd really hit on this is that I think is really worth thinking about is despite the debate and the intensity of the debate in Congress on where should we end up on health care, they started last February by reaching consensus that IT investment would be necessary predicate to getting to the results they wanted to get to. And as I said this morning, you had about a $40 billion market for health information technology in the whole public sector and commercial marketplace in the U.S., and they added about $25 billion. So and most of that money, even though the rest of ours is actually coming towards the end, most of that health IT money is starting now, or starting in January and playing out over the next few years. I won't go through all this, but this is not a bad picture. It's in the document we handed out to give you how broad this discussion is. So you've got $17 billion on electronic health records. You've got a broadband strategy, a telehealth strategy, community health centers through HRSA and ONC. You've got entities on this right side that didn't exist a year ago. So you're talking about pretty profound change. Beacon community grants, regional extension centers. There are entities and players that are going to influence this service marketplace that weren't even conceived of 18 months ago. Okay, so we're in the midst of change. And then you have two planning strategies that are coming out. One is the cooperative agreement plan, the HIE plan. The other is the state Medicaid HIT plan, and Jim, I think, is going to reference this as it relates to New York. But a lot of activity coming at the intersect of both of those. And then on top of that, the question of how do we connect this not only to the commercial and public sector health, but across from public sector health to public sector, the rest of public sector government in a state. Talked about the complexity of services to a consumer. That is the picture of the era high-tech environment. And as I mentioned, on the right side, you have a lot of players that didn't exist in the past. But even though that's complex, so I could go on forever on this, and I won't. I'll just make this statement. You don't find ONC and CMS too far apart. The CMS meaningful use, which was, we were writing this weekend, but they come out with 500 pages, right? But the meaningful use thinking, the dedication and focus right now on this topic coming out of ONC is pretty significant. And by that, I'm not understating the issues that can exist between all these players up here, but there's a pretty strong sense of, and some pretty capable people are driving an agenda right now. So, and that plays into the planning process and all of the rest that I talked about a second ago. I'm not going to go too into this, but to say, and we've been talking a lot about this with governors and elsewhere, the nature of the crisis, the nature of the opportunity, the investment into health, in the growth in health. No matter what happens in health reform, Medicaid's jumping up continuously, right? And it's going to cut into higher education, right? It's going to cut into other services. So from the governor's point of view, this has all of a sudden raised the stakes pretty dramatically in terms of focusing on state planning and implementation, financial sustainability. Finance directors are much more relevant and on top of this topic than they would have been in the past. State Medicaid leadership, when we look at the country right now, you look at the role of the state Medicaid or health leadership in the state, their decisions now are not only have a disproportionate impact on the size of the state budget, right, but it's growing. And politically, their decisions affect the relationship of the governor with the commercial health care marketplace. So the importance of the roles of these individuals, you look at the work Carol Steckel has done, the work that many of the others in the room that get this point right now in terms of how do we move this marketplace and how in the raising importance of these players. Universities more important, and the CIOs, NASTIO put out a paper on this a few months back, but the importance and the opportunity for the CIOs as trusted advisors on this question of interoperability. So I'm going to just show you a quick picture. This is something we did in a discussion in a couple states. This is just the state agencies, basically, with Medicaid in the center. And if you were to look from, say, 2009 to 2009, you had a lot of momentum begin, and up there is just a service-oriented architecture that started to talk about how do we connect some of these systems across. And Stewards of Change has had a number of discussions the past few years with models, some of them in the child welfare space, some of them child welfare behavioral, some of them counties as in Allegheny or in Montgomery. So that's some of the thinking that occurred. When the stimulus occurred, it all of a sudden drove right down on that vertical line all of the health industry, commercial and public sector. And the interesting thing, in some ways at the state level, is it put Medicaid right in the center of it. So CMS is right in the center of it on the Medicare side as well, but from a state perspective, where some of these states would have wanted to keep at arm's length from this because they don't know if there's a sustainable business model for HIEs, they're worried about it. Now they're right in the center of it because they've got $17 billion they're going to sign off on at the federal and or state level. So we are going to see models that are evolving on a horizontal line that will implicate the vertical line and vice versa. Common Client Index, which identifies consumers across multiple systems, which has evolved in the US and Europe and in many parts of the country on that horizontal line, is also a requirement for health information exchange. So we're going to be thinking about a lot of ways about, well, how do you build technology that you can make extensible up and down these lines? And you'll see models evolving, and we're already seeing them in different parts of the country. So a few points on where do we think things are going to go. Medical homes, which we'll have some discussion on the panel, but the whole idea of coordinated community care for at-risk and underserved populations, and by that I mean a little more than medical homes in quotes, but the idea of community primary care coordination, community health centers, medical homes, chronic care coordination strategies. Some examples in the states, and where do we look for innovation? I'm going to move off of the medical homes because it'll be discussed. This picture is actually Kevin Kearns, so he'll be talking something about some of this. I mentioned Alabama, and I want to mention it again for a moment. You had a governor who was focused on efficiency, access, quality. They had what was called the smart government strategy, economic development, rural education, IT development, health and human service, and not far, actually, in terms of, I mean, the thinking was very, very similar to what Governor Manchin talked about today, in terms of you're talking about states that have a sense of urgency and an absolute commitment to enhancing the outcomes for the citizenry. What Director Steckel did and the Medicaid Transformation Grant, connecting strategy with Blue Cross and the providers, and now looking towards extending consumer access to their own health care, what they had done on a blueprint for connecting health and human services through their Camellia strategy. And just a point here, because it's pretty significant, the citizen well-being poll is being run every day by Gallup and Healthways. The citizen well-being of Alabama has jumped up to 33rd in the country, which is really significant, because those were the benchmarks the governor was looking at. I'm 48th or 47th or 45th. How can I get to be where Delaware is or Rhode Island? And so when I was at the NGA, when the governors as a group were presented this data, and it really struck people's attention that, wow, when you start to come out a coordinated approach to your citizenry and a strategy, you can get significant results. Kentucky, I'm going to go past this, but they've done some very interesting stuff on children's health records and connecting, and now a strategy towards connecting human services. West Virginia, Roger will talk about this. Wisconsin's interesting because they've developed a strategy with the emergency departments and Medicaid, and they're doing a data aggregation piece so that and they're showing results are coming out of Wisconsin right now similar to what we're all talking about, which is how does this reduce spending? How does it change the disposition or the diagnosis of doctors? And so we're seeing some real movement in there in that environment. I'm going to make a few closing comments. On the IT, you're going to see services in the cloud. A lot of discussion about how do we develop and leverage services through the internet, and we're seeing that. We're going to see data liquidity. It's irrelevant where the software or the data is physically. We're going to see a discussion as social network and collaboration is just taking off, and how that plays into case coordination is going to be something interesting to play out. We will have innovation in financing. And we're in the paper, we talk about two things. Sustainability models for HIE are going to drive a lot of models. A utility model like Vermont, rate-setting themes like Maryland, finance through reduced cost savings, reducing costs through innovation and IT scale, which is what I was just getting at. You're going to find some very innovative ideas coming out of the intersect of the IT industry and governors around, hey, maybe for a set price you could put an HIE together for everybody in your state. How do you do that? But the other point, and there was a lot of discussion here on this in the last day or two, was the whole idea of financing through rationalizing government's disconnected funding and oversight. And I think that's a real opportunity. I know Rick is going to get to some of those themes later, but we do have disconnected systems. We have the APD process and the waiver process is brutal. At a time where the governors are actually being asked proactively to connect strategies with the commercial and the public sector healthcare market, they're stymied by the ability to connect strategies between children and family services and child care and health. And I think you're going to find them moving the ball on that with this administration, saying we want to free up our ability to do that. And I think there's a real opportunity there with people like Governor Manchin. And I've got the national HHS architecture, which I think Rick might go to some of that. I'm wrapping it up, Vernon. I think where to look for innovation. Size of jurisdiction, and by that I don't mean just the state. So I think in the political leadership, the state, you take a guy like Governor Manchin, he's incoming chair of the governors and has serious access to the president and to everybody who matters right now. So it's easier in some ways in a smaller jurisdiction with the right leadership on the political side for him to get some consensus on some themes faster. So my point on that is, even on the larger jurisdictions, it behooves some of the leadership in the room to think about how do we support those people to move the ball, because they can take that risk and put that voice out there on these things. But having said that, on the size of the jurisdiction, I also think that models, in like Jim Figge will talk about, models in places like New York and places like Harlem or in places in the rural parts of the country, being able to get your arms around it so you can succeed will matter. Stability of the leadership, streamlined decision-making, history of success, funding streams that you've proven you could get through the foundations or federal agencies or state agencies. Everybody's risk-averse. If they're putting money in, it's more likely the others will put it in if you did it right. Urgency. Governors are major concerned about the economic and workforce development. And then look to the community, and I'm going to end it with that. But by the community, what I mean is, as I said, we have new community entities like regional extension centers that will be formed. We have medical home models that have come out of the healthcare community health that can easily be integrated once you get to the right jurisdiction and think about your consumer. You could easily integrate your community medical home strategy with your child welfare, at-risk juvenile justice, public health. And you could leverage the revenue that will flow into those medical homes or community health models to connect into those human service models. And I think that is where we're hoping to see this discussion move. So with that, I'm going to kick this over to Roger Chaufournier.
Thank you, Bill. As Bill said, I have had the honor and privilege of working in West Virginia with Sonia Chambers and the rest of their healthcare team on really helping West Virginia become a national laboratory for innovation. My day job is running a healthcare innovation company. I play where Dr. Ray talked about those innovation curves. I'm at that third curve, trying to figure out how to push to that high productivity, low cost end of the spectrum. On a micro level, working with individual physician practices on redesign of care team and new models and templates for decision support. And at the macro level, working with states, healthcare authorities, other groups on transforming the health of the population. In all of that work, data and information is critical to disruptive information. You manage what you measure, is the old axiom saying. And data is really the voice of the process. It tells you how productive you are, what direction you need to focus on. You can focus on diapers if that information is transparent, and you know what the cost is, and you know what should be done. You can then influence the process. I'd like to offer 4 key assertions, if you will, as we talk about interoperability, interoptimization, that really should be in the back of our mind of design challenges and questions that we need to address in all this work. The first one is that as we develop our strategies for optimization, we need to blur the boundaries of the organization to include non-traditional partners that we're not familiar with and used to working with in the past. And I'll give some examples. Secondly, we need to leverage partnerships to achieve what can't be done as a state agency or as a solo player on our own. Third, we need to create new shared organizational structures that lead to sustainable solutions over time, rather than solo-funded projects with short half-lives. And then lastly, technology and information alone will not accomplish the transformation unless it's connected to mechanisms to drive the transformation process. So with all of that, let's talk about an example. State Medicaid agencies are facing one of the greatest challenges in their history as we look at what's happened with the economy and the growing Medicaid rolls, even before all of the changes of the federal reform. And then we add on to that the federal stimulus opportunities, where now state Medicaid is going to be expected to take on the challenge of administering the new incentives. We think about now with federal health reform possibly adding 30% to the rolls that the state is going to have to administer at a time when state budgets are constrained, and as Governor Manchin said, often the state staff are understaffed, underpaid, have huge bureaucracy challenges in terms of navigating additional positions. So if we continue business as usual, the Medicaid agencies cannot achieve this new mandate unless they reinvent themselves and unless they seek these new partnerships. But the issue gets even more complicated as we think about these boundaries. When we take on this new population and think about what has to be done, this new population is also likely to be the ones that have the additional burden of illness and cost due to some of the factors of the economy. And all of the resources are being poured into the healthcare system, to the delivery system, all the dollars in investment in IT informatics. And we're expecting to change things that are often outside our control. Most of you are familiar with the work on social determinants of health. And if the data is actually accurate, that 10 to 25% are really due to the healthcare system, with the rest of it being community-based activities, it begins to challenge some of our assumptions of where are we moving in terms of how we're using this technology. And if it goes even further, when you start to think about how often the healthcare system is in contact with a patient. If you have a chronic disease such as diabetes and you're coming in 4 to 6 times a year and you have an 8-minute slot with a provider, so you have 48 minutes a year, we're supposed to help you transform your health and take care of all these social determinants of health, it's not going to happen. Yet we know they're spending 120,000 minutes a year in work. So here's a huge leverage point. What are the implications of that in terms of the flow of information, the security issues, and many of the things that we spoke of yesterday? So let's talk about some of these 4 assertions. This is an example of some work going on in Michigan in a community that has been grappling the challenges of the medical home concepts. Obviously something very innovative. I believe the medical home concepts with the Wagner care model underpinning it, with practice redesign supporting it, is a disruptive technology in healthcare. We're seeing leaps in potential productivity in the magnitude of 20 to 50% per capita cost reductions with a new model in this regard. But when you start to think about what is a medical home, is it a medical home or is it a healthcare home? And who has to be involved as part of that delivery model? And we start to talk about the role of the care coordinator, getting at a micro level. How is that actually being acted out in the field? We see very different mechanisms evolving. And this notion that in this particular community, they began to realize that the traditional care manager may not belong at the payer level. It may not belong at the hospital level. It may not belong at the practice level. If you're a solo practice and you only have a certain number of people with chronic disease that need that acute care management, you can't afford the carrying cost of an FTE to do that. You have to have a shared resource. Well, if that shared resource is now in communities, as we've seen in states like Vermont and North Carolina and Michigan and elsewhere, what are the implications for the information flow across this system to make all of this work? And how to create this data liquidity in these new frontiers. It also suggests we have to have new organizational structures. Not far from here in New Hampshire, there was a 14-county, 14-municipality area with no public health infrastructure, no public health departments. Huge unemployment, huge health burden of illness. Those 14 counties came together, those 14 municipalities came together with community agencies and formed a virtual coalition, which evolved into a 501c3 and is now a new governing entity managing the health of the community. And they are the ones responsible for transcending the flow of information and beginning to provide the electronic health records to the practices rather than the practices acquiring this on their own model. A very different frame of reference when we start to think about how these organic systems are evolving. And when we look at most of the investment in the EMR technology, which is where most of our attention is focused, a lot of those systems have evolved out of hospital-based systems, morphed to ambulatory, but not have evolved with the community needs and the broader spectrum of the players involved. In the same community, then they get to a granular level. If we want to start to take the information and now start to change the health status, this is an example of working with obesity. And how do we start to look at tracking BMIs as a starting point? And when they look at the base data, they see that 13% of the time they're capturing BMIs on children or people coming into the practice. Well, what has to change in order to be able to do that? We have to start to change the screens and the data elements that are in the EMR. We have to start to put in techniques for the care team on motivational interviewing and how to get and engage the population. We have to go beyond to start to find some community interventions in terms of walking trails and guides and what they can do with their employer groups. And this all has to be integrated and then tracked with a common aim in a transparent way. And when you do that, you can move from 13% up to now where we see in excess of 75% of the time people are capturing the BMIs and they can now target the interventions to the populations that they need. West Virginia is an example where, again, an opportunity to bring together new organizational structures to help provide the laboratory for innovation. In West Virginia specifically, through a Medicaid transformation grant, the stakeholders in the state were brought together, including all of the state agencies, the healthcare systems, the advocacy groups, all of the infrastructure that represents the healthcare system, and asked to collaborate on priority opportunities. These were not dictated, but organically came from the community saying, what are the priorities we'd like to work on then? Out of that came work groups that individuals took voluntary lead to chair the work groups, and then within each of those work groups, focusing on specific issues. So, for example, one of the work groups included all the payers working together to establish a common set of measures and definitions that can be tracked across all payers, rather than creating an additional burden of reporting and having different measure sets for the same issues in the community. They recruited an innovation laboratory of early adopter practices that could serve as the fodder for pilots for innovative programs on how to move forward and test some of these ideas and be able to accelerate the change with all of this. The results that we start to see when you start to marry what was talked about before in terms of information with mechanisms of delivery, a project, for example, that Sonia's worked on. We're looking at where are some of the high opportunity costs in the state for management and looking at public health issues in terms of infant mortality, neonatal deaths, NICU cost in the organization. When starting to look at the data, seeing that some of the hospitals having 35% rates of induction in a C-section without medical necessity under 39 weeks. Unexplainable. And how do you change that? What do you begin to move? Well, when you bring the groups together and you provide them the data, you provide them a mechanism to share the best practices, and then drive that in a disciplined way, begin to see huge progress. And in that particular case, I think it was about 8% they were able to drive down from a statewide average of 22% down to 8% as a result of those kind of efforts. So with those kind of innovation laboratories, you could begin to make the breakthroughs and see them forward. In the area of HIT, in the beginning to develop rational strategies, after a year of work developing this coalition, this goodwill of collaboration, this shared ownership, if you will, across the community, they were able to move forward and begin to tackle the challenges. How do we develop a rational statewide plan for information technology that can serve as a framework to guide what we should do in terms of exchange of information? What should we do in terms of capital investments in the state? What do we need to do in terms of integrating and connecting the players? And as a result of that, they, in a very rapid cycle, beginning in May and concluding in June, developed a statewide strategic plan using a small work group, crafted a straw man, and then brought together all the state players and said, here's the plan. It's a straw man. It's not etched in stone, but this is based on the best information we have. It's based on prior existing plans. Does this make sense? Is this the rational strategy for the state? Can this serve as the glue to now allow us to go and fulfill our individual mandates and begin to accelerate the adoption and efforts? It helped put a lot of the dialogue that had been going on in health information exchange into a context of how it fits in with other pieces. It helped better clarify what role the Regional Extension Center might play and how that should be organized in the state. It began to start to look at, well, this is all great, but what about the workforce issues that you heard Governor Manchin talking about? Well, what are the challenges going to be? Where are we going to get the people to do the data networking, the data analysis, the data entry? What needs to be done at the medical school level in terms of the training of health professionals and the use of electronic health technology, and how to take the decision support tools, the analysis and the data, and translate that into action in the field. And through this integrated roadmap, then, each of the individual entities can go out and carry on their existing mission and mandate. So technology can serve as an integrator and an accelerator of improvement. To do so, though, it must be connected to and associated with advances in collaboration. New mechanisms, new organizational structures, new ways of connecting people to action that before were very, very strange players. Not too far from here in Massachusetts, a great example of this new concept of developing perhaps an enterprise business model. A community health center, Holyoke Health Center, in Massachusetts was starving for behavioral health resources, and across the street was a not-for-profit behavioral health organization that they often contracted with. And that particular community is the largest concentration of Puerto Ricans in the United States. So they have Hispanic needs that weren't being met. And they were over constantly trying to get this behavioral health provider to find ways to recruit and increase Spanish-speaking providers. And all of a sudden, they started talking about their co-needs as businesses, two separate organizations. But what if we started acting like one? What if we co-located? What if our staff are treating are in your clinic? What if we start doing joint budgeting? Why don't we start doing joint grant application? Let's maintain our independent status, but let's start to collaborate in a very different way. And through that, they were able to skyrocket and bridge the gaps in terms of their behavioral needs. They were able to keep the business model of the behavioral needs specialists to be able to recruit in the Spanish-speaking because they had the fodder and patient base, and through the merging of technology then being able to share information on how to best optimize the system and support the new model. Thank you very much.
Kevin Kearns, Health Choice Network.
Thank you, Bill, and thank you to Daniel and Jerry, Vernon, and everyone for the opportunity to be here. The governor mentioned how difficult time it is to get it from West Virginia. It wasn't difficult from Florida, but I will say I had to go up in the attic to find my coat and my gloves, so my body's going through the shock right now, but I think I'm getting there. But I've been working with the community health centers for 18 years now, and I was talking to Vernon last night, and it's so refreshing to be at at a conference like this to hear some of the thoughts and exchanges of information, because I do believe, as the governor was talking about, that there may be enough money in the healthcare system today, but I think we all agree it's not being utilized effectively and efficiently. And if there's a way that we can put our heads together and really figure out how to make the best use of those dollars, we'll be better off. And that really is what is behind Health Choice Network and what we've been working on over the last several years. I'd start with one data slide, and I think there's some updated numbers here today, and I think Bill alluded to it, that we're spending close to 18% or so of GDP on health care. The news today, maybe some of you saw, we actually spending went down. The increase went down. We're at 4.4% increase in healthcare spending last year. It's still $7,600 per capita in this country that we're spending on healthcare. And you can see up there where it goes. A lot of it, and I certainly agree with the governor, doesn't go to the primary care and prevention and wellness as it should, and that's certainly one of our missions. Our focus with the community health centers is on the medically disenfranchised. Just because you have health insurance doesn't mean you have access to care. And that's really something that I didn't understand until I got involved with the health centers. 45 million, depending on the numbers in the studies, 45 million uninsured. And I'll look to Susan to help me out. I think there's about 10 million of the uninsured are seen in the health centers and the FQHCs, and I'll talk about them in a minute. But I think we'd all agree that there's a fragmented healthcare delivery system, and utilizing technology is what we are trying to work on to really help that issue. My life for the last 18 years has been with the federal qualified health centers. I'm curious, I know there's a lot of child welfare, child foster care. How many of you all have worked with the community health centers, the FQHCs in your area? Yeah, a few. Maybe we need to I'll tell you, one of my takeaways from yesterday, I would say that I think we have a good track record of working with those entities in our communities, but I had not really thought about, as much as I should have, being able to the interoperability with those organizations. I'm so focused on healthcare and the hospitals and the labs and the DMEs and all those entities, but I think certainly for me, the takeaway from here is going to be really making sure that we reach out to those agencies and be able to work on the interoperability down the road. The health centers really define, in my opinion, medical home before you heard a lot about the medical homes. When you're dealing with uninsured patients, you don't have the luxury of referring them to any provider you'd like to or working on contracts. The health centers get, in essence, a capitated amount every year to take care of the uninsured. And that's it. They don't get on a fee-for-service, so I guess you could say the risk of fraud is less because they can't go to the well and churn the services. They have to take those dollars and make the best use of them to take care of the patients. Consequently, similar to I guess, the West Virginia, we do as much as we can in the community health centers with the information that we have. And you see all the services that we provide. The migrant seasonal farm workers are a key part of who we serve. Mental health component, that oral health, I hope is up there somewhere. We think those areas particularly are important when you look at the total health care of the patients. It's a $2 billion program at HHS, about 1,200 community health centers across the country. And they provide, it's about 18 million patients that they serve in total. Again, about 10 million of those uninsured. Recently, Bill alluded to some of the stimulus dollars that they received, about $2 billion in stimulus. That equates to 1 year of funding to focus on capital improvements, expansion of services, and what's near and dear to my heart, improvements in health information technology. So what I do as a health center controlled network, and you heard Susan talk about it yesterday, is we work with a number of community health centers in Florida and 7 other states across the country to help them leverage technology and to work on other strategic initiatives. We are a not-for-profit organization, as most of them are, and really our claim to fame has been implementing the technology, which I'll talk about in the health centers. I put up our mission statement for a reason here. I know you all have seen many mission statements, but I think ours is telling because there are 2 components in here that we do. One is, which Susan I'm sure talked about yesterday, is providing the service and support to our centers, the efficiency, the economies of scale of working together and centralizing the IT operations, some of the finance operations, the billing operations, to really make sure we maximize the dollars that come into the precious resources that come into the community health centers. And that's probably what we're most known for, is start implementing the technology, serving as the center's chief information officer. But the second piece on there is probably equally, maybe more important, acting as a vehicle for strategic efforts. We found that it's not good enough just to implement the electronic medical records. I mean, we're proud of the adoption rates that Susan talked about yesterday, but until we're able to utilize technology to help get to the next level, to help improve the medical home, to help promote quality outcomes, we really haven't done our jobs. And so what we've been focusing on really, and I'm going to give some examples, is the way that we've been able to use technology to help our health centers get involved in other strategic initiatives to help meet their missions of serving the uninsured and the safety net. All right. Just one blurb on who we are. But 750,000 patients served. I have to qualify that. That's in the last 12 months. I mean, we have about 2 million patients, unique patients, on our database over the last 2 or 3 years. But the way that we count them for HHS is that they have to have had a medical visit within the last year. But we work with a number of mental health clinicians, 49 centers across the country, 457 providers. Just about all of these are on an electronic health record today, and if not, they're about to be an electronic health record. We work in, as I mentioned, 9 states. Actually, some of the pictures of our health centers, and the one at the bottom there in La Casa is in Portales, New Mexico. I promise you they would not have the technology today without the services of an entity like ours that can provide the resources so that they can really utilize the economies, take advantage of some federal resources that are out there to implement the technology in their center. This slide, each one of these boxes could almost be a whole other presentation. I know that Vernon's there getting ready to put up the slides there, put up the time, but try to separate these. The orange, really, when we look at our mission, the focusing on provide service and support. We provide, I'll talk about in one other slide, the CIO services, implementing the centralized technology, focus on the electronic health record, practice redesign, centralized billing. I couldn't agree with the governor more. If they do anything, at least fix the billing to make it consistent. It is so frustrating and wasteful in the formatting that's required to get the bills paid. But we try to make that easier for the centers and hopefully save them some of their resources. We work with Health Information Exchange, and then I'm going to talk about the regional extension centers and our Prestige Health Choices, our managed care contract. I want to mention the behavioral health up there. One of the things that our technology enabled us to do is partner with a behavioral health entity, Magellan. Many of you may know Magellan, that has bid and was awarded the contract in Miami-Dade County to provide the behavioral health services for about 70,000 Medicaid patients. We were their community partner to be able to do that. And we focused our health centers as the core providers. We had to have the technology to be able to do that, to tie it into the clinical environment. Most of our health centers provide behavioral health services. 2 of them in Miami-Dade County also have the designation of a community mental health center. And this was an opportunity that I think the network brought to them, the technology brought, to be able to take advantage of the resources and really utilize the dollars in behavioral health. I joked about, you hear about all the fraud in Miami-Dade County. It is true and it is terrible. The one good thing about it is it's kept the rates up so that when you're doing honest business of a managed care provider, you get a rate that can probably pay for enough of the services and save a few dollars at the end of the day. But we are really looking at how do we tie in the clinical services and the behavioral health services, get them all on one patient record. We are also involved heavily in school health. There's an entity in South Florida called the Children's Trust that has an ad valorem tax that brings in $100 million to just focus on children's issues, not just underserved children, but all children within the county. And one of their key initiatives is they want to see a school-based health center in all of the 355 Miami-Dade public schools. Today, they're in about 120 of those, and our centers provide those services for about 80 community health centers, school-based health centers. An incredible opportunity, I think, for our centers to make sure that we get to the kids early, that we not only provide the services in the schools, which is, again, agree with the governor, so critical, but now they have a medical home. When they need those additional services or they need dental services that aren't in the schools, they're able to refer those to the mothership, we'll call it, of the community health centers to be able to provide those services. So that has been just incredible now to have, and you'll see on a slide, we have 130-some thousand children in Miami-Dade now with an electronic health record. We also have some health promotion programs. We've worked with a faith-based community. We found that is a very successful way of getting to the populations we serve. They may not want to come in to get a medical visit or a dental visit, but they're going to listen to their preacher on Sunday morning. And if they say you need to come and have your health care needs addressed, and we put on a health fair, they'll do that. And we found some good success in reaching the community that we otherwise may not be able to reach. This is our version of interoperability, and I don't want to mislead anybody that it really is interoperable. But we have our focus at the network. As I mentioned, we provide the central CIO services. We have the database, we have the servers, everything is housed at Terramark in South Florida, which is the most secure systems you can get. The Department of Defense is in there. So our health centers don't have PCs to speak of. They don't have servers. They have thin clients. They're able to access the internet, their email, everything directly from our system. So we have one common network operations center that helps manage that information and implement the technology. And it's our responsibility to connect. We actually have a center in West Virginia. It's our responsibility to connect that center to the health information exchange efforts. It's our responsibility to connect we're connected to the Florida SHOT system for the immunization database. We serve as the CIO for the centers and make sure that they're connected. Meaningful use, the definition's just coming out. I'd suggest that we are a ways down from meaningful use. I mentioned the kids with electronic health records. The data's available. We can share with a continuity of care record with any of the health information exchanges with the state, interface with the immunization system and the state of Florida and others. We heard some numbers about obesity. We found that in some of our schools, 41% of the students are overweight. Yeah, that's an issue we've got to address, and I think that really ties well with some of the children's advocate issues that we're hearing about today. We are able to demonstrate our clinicians can go on and find out in the system real time how their population of patients, diabetic patients, blood sugar level is compared to their colleagues, their other providers or other centers. We're able to put interventions in place, and we've got data that 26% decrease in their HbA1c levels, the blood sugar levels of diabetic patients. Very important in determining outcomes and preventing long-term illness down the road. The Regional Extension Center, Bill mentioned, we are very fortunate, very proud to have put together this coalition. I look at Susan and kind of smirk that the little community health center and the network of health centers has now put together the Jackson Memorial Hospital and Broward Health, University of Miami, both of the Broward hospital districts, and we are the lead applicant for the Regional Extension Center. We hope that we will be successful, but it really is an opportunity to bring in all of these partners together. And I've said many times that part of the requirements of Regional Extension Center is you're a not-for-profit organization, you have experience in implementing technology in safety net providers. I don't know there's a whole lot of people that can say that. And that's been our life. When I say ours, the broader network community that Susan and Cheryl had worked so much with. So we think this is an opportunity really to affect change, to really increase that adoption, and then more importantly be able to utilize the exchanges and promote quality outcomes. And finally, one of our other key initiatives, which is a year old now, that's all, the health centers, when they did Medicaid reform in Florida, we said, well, we have two options. We can continue to be beholden to the HMOs and take their rates and their authorization practices and all the administrative burden that's put on us, or we can go out and start our own managed care organizations. They chose the latter. And the FQHCs that we work with in Florida, about 20 of them started this company called Prestige. It is a for-profit organization, owned majority by the not-for-profit community health centers. We went from 3 Medicaid lives in December of 2008 to now over 41,000 lives as of January, and just about a year later. And the significance here is the focus, as you would imagine, is on primary care, prevention, wellness. And it gives us the opportunity, without the state dictating and what we get paid for and how we file a claim, it gives us the ability to have some flexibility in implementing those services to the patients that we serve. The behavioral health component we want to be able to add. We're not doing the behavioral health yet, although we're responsible for the medications, but that's a whole other story. But I say with our managed care organization, we have two distinct, fairly unique advantages. One, we really do provide a medical home. When that patient loses Medicaid coverage, guess what? They come right back to the same community health center. They get the same quality of care they've had, the same prescriptions. Find me another HMO that's going to say when you lose your coverage, you can still come see our providers. Second, we provide an electronic health record. Find another HMO that can say we provide our patients, predominantly all of them, because our community health centers are based, with an electronic health record. So we think that gives us an opportunity to succeed. Again, it's only been a year, so the verdict's out, but we have had very positive results, which is what was expected. There are plenty of studies out there that demonstrate the effectiveness of the federally qualified health centers in controlling the cost of care. And so all we want to be able to do from a business perspective is utilize that, hopefully save a few pennies at the end of the day to return back to the centers, but more importantly to provide a much higher quality of care for the patients where we can control the focus of primary care and prevention on our patients. And I think that's it. Did I do okay? All right, we're good. Thank you.
Jim?
I wanted to thank Bill and Dan for inviting New York Medicaid to this great conference. Hope everybody's learning as much as I am. I'm going to give you a big state perspective on some problems that we're facing in New York. We've heard a lot of information from some of the smaller states, and I want you to see what we're facing in a very large state with a very large program and some very complex management issues. We're going to talk about interoperability and how we think that can be the cornerstone of helping us improve our care and coordination of care in New York State in the Medicaid program. Let me just give you some basic facts to get you oriented to the program. If we were a corporation, we would be in the top 15. We're a $47 billion operation. We have 1/5 of the population of New York State receiving their health insurance coverage through us. That's more than 4 million people out of 19 million in the state. We have over 70,000 providers of various types. And we have to manage all this. We have no more than 8 agencies that I can think of that are involved in administering the Medicaid program. We have some of the folks who are my colleagues from some of these agencies here today, and we'll introduce them in a minute, but let me just give you a little bit of insight into the complexity of the management. So we have the New York State Department of Health, which is the flagship organization, the Office of Health Insurance Programs. We oversee Medicaid in most of its administration, but we also oversee more than 20 managed care organizations in New York State. Many of them are involved in administering Medicaid. We have more than 20 Medicaid plans. We have 3 behavioral health agencies, Office of Mental Health, Office of Mental Retardation and Developmental Disabilities, and Office of Alcoholism and Substance Abuse. We have an Office for Children and Family Services that administers foster care, which interfaces with Medicaid. We have Office of Public Health that interfaces in some areas with Medicaid, for example, our Vaccines for Children program. We have a number of other offices that provide administrative services and support. These are all silos, and we really need to incorporate the principles of interoperability to start moving information through these organizations because we're all touching on the same beneficiaries. We are responsible for 45% of the births in New York. We have 40% of the children in New York. So we have a tremendous responsibility to take care of the children in our state. And many of the organizations that I just mentioned touch on children. So we have to really figure out how we can do a better job of coordinating care, moving information across these silos, and improving the quality of care. So the HITECH Act under ERA provides us with a unique funding opportunity which will give us some tools in the form of health information technology, health information exchange, so that we can really start thinking very carefully how do we use these tools in such an enormous operation to really do a better job coordinating care and improving outcomes, because that's what this is all about. As was said yesterday, this is all about getting to the outcomes we want for our patients. Let me just take a minute to let the rest of the members of our team from New York stand up a minute, and I'll give them a second to introduce themselves. Bill, do you want to start?
My name is Bill Travis. I'm the CIO for the New York State Office of Children and Family Services. We embarked on this conversation with the Department of Health about a year ago, It has been a conversation, it's an evolving conversation. We see this to be a significant benefit in our child welfare as well as our juvenile justice areas. You know, and when we have children that present with unknown needs, it requires us to spend a lot of cycles to try to identify and be able to be reactive and manage those needs. We see this as a tremendous opportunity to have information to inform that decision-making process at the front door during intake rather than it being reactive. So we do appreciate the opportunity to work with Dr. Figge and you reaching out to us. That's what it's all about. Thanks.
Okay.
I'm Max Schaller. I'm Executive Deputy Commissioner for the Office of Mental Retardation and Developmental Disabilities. And I think that what Dr. Figge is going to be talking about really demonstrates the commitment that this administration initiated about 3 years ago to move into the area of interoperability with some real teeth behind it. So we're very interested in this project, and we're very interested in what we're learning in these 2 days and tomorrow.
Great. So our vision in New York Medicaid is to develop a patient-centered state Medicaid HIE plan for New York. We want to leverage the Recovery Act meaningful use dollars, which you heard about yesterday, and also the 90-10 Medicaid administrative funds to create and implement a 5-year statewide patient-centered Medicaid HIE plan. I could talk all day about this, but what I'm going to do today is give you some of the high-level details of what we're envisioning for the plan, and then we'll talk a little bit about our ideas for health information exchange and interoperability to really keep it focused for today's presentation. So from a high-level perspective, clearly we want to use the money to support HIT adoption and clinical practice workflow reengineering. We know that without the reengineering effort at the ground level with individual practices, the adoption rates will be very low. So there has to be a tremendous amount of thought and effort put into that particular type of work. And New York Medicaid will be working very closely with our regional extension centers to try to get that on-the-ground support. As you heard yesterday, part of the money will be used directly to incentivize the meaningful use of electronic health record technology. This will be for our clinicians who are eligible to participate in the Medicaid program, and also for most of our hospitals in New York, which will be eligible to get both the Medicaid and Medicare incentive monies. And then, as I mentioned, we want to use the money to help improve care coordination through the use of clinical data that will be distributed in an interoperable way through health information exchange. And I'll focus on that in a little bit more detail in a minute. Continuing with some of the high-level objectives, we want to improve patient safety by incentivizing electronic prescribing. This is an area of health information exchange that's more mature than many other areas, and we are actually putting both state and federal dollars on the table to try to incentivize increased adoption of electronic prescribing as an early activity that hopefully will be able to start up even before the Recovery Act incentive starts. We, too, are very interested in the patient-centered medical home model. I won't get into details of that because you've already heard a discussion of it, but we also have a state budget incentive program for incentivizing the creation and development of patient-centered medical homes amongst our primary care providers. So we're putting state dollars on the table for both of these incentive programs. And then at the end of the day, after the incentive money is put out on the table and we have our medical homes and we have people engaging in HIE, we still need to be able to ascertain that we're actually having an impact in the areas I mentioned on improving coordination and quality of care. That is our ultimate goal using these tools, and we need to have a way to measure that. So we will be very interested in looking at the electronically reported clinical quality metrics that can be derived from electronic health records. Right now, we've got 15 years of experience in New York State Medicaid working through our managed care organizations in measuring a set of metrics and our HITECH quar metrics. This is a standardized data collection. It's a very painful data collection because much of it is chart review. It's very manually intensive labor to go through charts and pull this clinical information, but it's much more useful than just looking at claims data. And with electronic health records, that whole process can now be automated, and we'll be able to get a combination of claims and clinical data that can be very valuable in looking at where we are with various processes and outcomes that we're interested in. So this will be a very important activity, maybe not immediately in 2011, but a little bit further down the road, by 2012, 2013, when we really start looking at where are we going, what are the benchmarks, what are the outcomes. Okay, I want to switch gears now and talk a little bit about our vision for HIE in the Medicaid program. As I've just explained to you, we have a very complex program, both from the perspective of the number of beneficiaries, the complexity of the health care needs of those beneficiaries, the complexity of our administrative processes, and just the sheer magnitude of the number of providers that we have to manage, along with 20 managed care organizations that we oversee. So this is a huge operation, and we're going to need to use the principles of interoperability to get to where we really want to go according to the vision that I just presented. So we're looking at the Medicaid data warehouse and the Medicaid MMIS system as being the workhorse, the engine, to provide a platform for health information exchange in the New York Medicaid program, and even perhaps beyond the borders of the program. That's why I brought in other members of state government who are involved in administrating pieces of Medicaid, because we really want to pull in all of our government partners into this endeavor, and we want to pull in our providers so that we have a very robust health information exchange program. We have a new Medicaid data warehouse hopefully on the way that will be state-of-the-art. It will have an enterprise service bus that's web-enabled that will enable us to distribute critical clinical information statewide, both to our internal partners in state government and to our external partners, our managed care organizations, our clinicians, and other providers. So we have very big plans for using the MMIS system and the warehouse as a mechanism for distributing this data. The warehouse will not be a traditional model. It'll be a hybrid model incorporating this data sharing capability. We're also working with our public health partners to develop common databases so that we can pull in public health information into the Medicaid system. We already have access to claims-based data. Medication history is currently one of our major areas of focus. We've done a pilot project with the New York City Primary Care Information Program by providing 90 days worth of medication history to clinicians on the ground. We're about to embark in a phase 2 program where we will be providing 180 days worth of data to selected business partners in the community. That will include the Primary Care Information Project and a couple of hospitals, for example, New York Presbyterian. That project will really allow us to test a lot of the features of our program before we go statewide. And I'll give you a little bit more information about that in a minute. We also plan to pull in other high-value clinical information, laboratory results. When I put my clinician's hat on and I'm working in a clinic, I often find it very difficult to get lab data that was ordered by another clinician, particularly with the population that I see, which is the developmentally disabled. If their caretakers don't bring in that data, I have to call all over the place. I have a nurse spend 30 minutes calling everywhere to try to find out what meds is this patient on, what labs have they had. It's very tedious, so we need a way of centralizing the distribution of that information, and the same thing for radiographic images. At the Chicago MMIS meeting, Dr. Blumenthal gave a great example of where a CT scan that was done a month ago, ordered by one clinician, could very well be used by another clinician if only that clinician could get access to the images and to see the results. So It's very important that this type of information be distributed around to clinicians, not only clinicians who are traditional medical providers, but clinicians in the behavioral health areas and caseworkers for foster care, et cetera. So we have many different types of individuals who could really benefit from using this information. And I mentioned the public health data. We're undergoing a major effort right now to incorporate public health data, specifically child health information, immunizations, lead and newborn screening, and possibly hearing, into our Medicaid data warehouse. And then here's where interoperability plays in. We want to populate a vehicle to distribute this information to all those users, the clinicians, case managers, other agencies that need the information to provide care and services to our population. And that's where an interoperable data format, the continuity of care document, comes into play, because we can take that interoperable format, pre-populate it with this information that we have, and then distribute it to end users who need that information. In many cases, there will have to be patient consent for this, and that's not so much because of HIPAA, it's more because of very strict state laws in New York. And then finally, I want to show this slide, which is a very high-level view of how we're developing the statewide health information network in New York. We're working on the principle of developing parallel interoperable pathways. We heard a little bit yesterday about experiments and failures. We've already had one pilot with New York City, which was technically flawless. We were able to move our medication history down to clinics in New York City with no technical problems whatsoever, but the project failed, and it failed because we didn't do what I told you we need to do. We need to get down into the physician offices, the clinics, and help them with the workflow reengineering. We didn't do that, and we got no adoption. We had 2 champion physicians that used the data. Nobody else used it. And it's because we didn't do the groundwork that was necessary. So yes, we failed in that project, what we learned from it. So now as we embark on a phase 2 project, we need to invest the resources on the front end and help the clinicians and clinics do the workflow reengineering that you need to do to get adoption. Otherwise, this whole effort will fail. And that's a very important message, and we learned that from our phase 1 trial. So failures do help you move forward. We learned that yesterday. We don't want to fail, though, this time around. That's why we have 3 parallel tracks that we're studying. Our partners at Microsoft are going to be coming in, working with us on personal health records. I mentioned that we're doing some of the work with New York Presbyterian Hospital in New York City. They have a very innovative approach to working with a community called Washington Heights, which has about 50% Medicaid population in that community. They're working with the clinicians in the community. They've put up kiosks so that patients can access their information through the Microsoft Health Vault. And what we're going to be doing is providing the Medicaid history, the medication history, directly down to New York Presbyterian. New York Presbyterian will then allow patients to put that information in their personal health record, and then the patients can control the distribution of that information back to their primary care physicians in the community. So we're really testing a bunch of concepts here in this phase 2 pilot project to see whether it's possible to engage patients, educate them about personal health records. Is it possible to get a very large, complex organization like New York Presbyterian on board and adopt this technology so that we can actually, engage in meaningful HIE, and then we'll measure metrics. The metrics can be reported back to our data warehouse. Are we, in fact, having an impact in improving the quality and coordination of care? We would predict that that would be the case. It's a hypothesis, and we need to, prove the point that this will work. We also have an extensive development of regional health information organizations in New York, and we're including them in another arm of this parallel interoperable pathway. We will be sending data through the RIOs into the Primary Care Information Project in New York City. That project now encompasses 300 clinics, about 1,500 clinicians serving over 1 million patients. So it'll be a very robust test of that concept. So we're going to be testing 3 concepts using the Medicaid data warehouse as one, personal health records as another, the RIOs as another, mixing them up, testing them in parallel, all following interoperable principles. Everything in this network has to be following the same rules of interoperability to make this work. And then we have to have some core services. We have to have privacy and security services. We talked a lot about that yesterday. That's absolutely critical to work that out. It has taken us 5 years of discussion in New York State to land on a common model. It's an affirmative, informed consent model. People have to opt in. They have to be explained why there's value to this and why should they want to opt in. We learned in our phase 1 pilot that this takes a lot of work. It takes a lot of time on the front-end office staff to explain to somebody what is this all about and why should they even think about opting into this. And then there's another problem that we haven't even talked about yet at this conference, which is identity management. Who is really asking for the information on the other end? We've got 70,000 providers. We've got 40,000 physicians in New York State. I don't know the names of all of them, but if somebody says they're Dr. Figge and they're asking for somebody's information, I have to be able to verify and validate that it's really Dr. Figge, that Dr. Figge has permission from the patient to get that information, and it's not somebody impersonating Dr. Figge. So there's this identity management issue that has to be dealt with. We've built that in to our phase 2 pilot using a very robust and elegant solution, which is called a public key infrastructure. It uses advanced mathematical principles to use cryptographic keys that we assign to institutions, and then we use national provider identifier numbers to identify individual clinicians. So we have a very sophisticated approach to identifying who's actually asking for the information. It's absolutely critical to do that if you want to maintain security and privacy, because if you have no controls on the ground level about who can ask for information, you have an open system. We're going over the internet, which is an open network, so you have to put those kind of controls in place. It goes along with the whole concept of interoperability. If you have interoperability, if you're using open networks, you have to superimpose the technical solutions for privacy and security. So very important principles and challenges. That's why we're bringing in partners like Microsoft, which are very experienced in implementing these kinds of tools, public key infrastructure. We're using our fiscal agent, which will be the certificate authority to issue the cryptographic security certificates to our providers. So there's a lot of work involved in actually rolling out a project of this magnitude. So again, if you think of us as a Fortune 500 company in the top 15, $47 billion operation with 70,000 stakeholders, this is a huge undertaking, very ambitious. We can't fail because this is really our opportunity to use the incentive money to make this work, so we intend to do everything we can by bringing in the best people to make this work. We did fail once, but we will not fail twice, so we'll leave you on that.
Hey, when people get a chance, I really would urge you to connect with Jim and Max and Bill. This is a state that is, in terms of the quality of the thinking on, there's a medical director who can translate technology with a CIO in ways that you don't see elsewhere, and that's true of all of their agency. Sure.
Okay. Well, I guess it's now officially good afternoon, and thank you again so much for allowing me to be here today. I want to go through this pretty quickly for a couple of reasons. One is I see in the room folks who had a lot of caffeine and want to hit the restrooms, and those who didn't, who need to get some caffeine, so I'll do that pretty fast. But you already know this. I look around the room, and not to comment on age, but I see thousands and thousands and thousands of person hours dedicated to what we're talking about here today. So I don't need to convince you about anything. I want you to think about the subtitle of Promoting Child Health and Wellbeing through HIT as Just Do It. Let's borrow from Nike. At the end of my presentation, you're going to have an assignment, and I've actually worked with some of you already and hope that you will take very seriously the request that I'll have at the end. And why am I up here today? As you heard, I used to run the CHIP program, and then I went over to the Health Resources and Services Administration less than 5 years ago to do this thing that I never heard of called HIT. And anyone who knows me, I'm the H, I'm not the IT side. So, I started going to meetings 5 days a week, 7 days a week, and no one ever mentioned kids. And I'm like, gee, this, kids sort of count in this society. And so I started asking and asking and asking, and finally doing, with help from Debbie Chang and Nemours and other groups, like, let's make sure kids are part of this. Kids are not little adults when it comes to HIT. So I'm going to go through a little bit of that. I'm a little schizophrenic because I was in the federal government. I'm actually with NORC now, and I'll give you my contact information. But the work that I'm talking about at the end is really for the Office of the National Coordinator, and that's why we finally, I think, have an opportunity to do it, and that's what I really want to focus on today. Oh, gosh. Okay, so this is about sharing information to promote child health and well-being, and I think that's so important because many of you represent many parts of the child health, and you've seen a million of these already. But this is just from the child perspective. And I often think, what if it was us? You know, could we really manage all of this? We have these expectations, particularly for low-income populations, that in a lot of ways none of us could ever meet. As a Fed, I never had to do anything, and I kept my Blue Cross Blue Shield. And, you know, we used to spend all this time, and we still spend all this time. Why can't those people just enroll in these programs? They're there. You know, don't they get it? Well, no. As a retiree now, I cannot figure out how to keep my health insurance. I'm like terrified I'm going to push the wrong button or something. So I'm now beginning to feel that a little bit. But it's the same child. I mean, we've been saying this for our whole time, and it's so exciting to be in a group like this that does represent multiple aspects of that child. So why HIT for children? It is a no-brainer. It is about the quality and the efficiency of health care and other services for children. And what I think is somewhat unique about children is that social service programs like a Head Start have health components. Health programs have social components. You heard about schools having health programs. So we have no choice but to be able to share this kind of information. If you talk to families of children with special health care needs, they literally walk around with boxes of materials in fear that any little piece of information at any time isn't available for their child. Well, now they can have flash drives or they can have personal health records. Personal health records have enormous power for children and their families. And it can really, when the child is ill, when there's a disaster, my first week of work in HIT was literally the week after Katrina. And they sent me up to Harvard to give this talk, and they said, just read this. And I can't use these words. I don't even know what this means. And I said, I'll tell you what it means. It was these children and veterans and others who were on chemotherapy, who were on dialysis, who literally overnight had no information. We were so busy trying to make sure that we would get kids all around the country, get them back in schools, get them back in programs. And people would call me, I didn't know the answer, saying, you know, how do I get this kid's immunization record or school record? They can't participate in school sports. That's what this is all about. There is no reason we should be doing that. As I said, children with special health care needs are certainly unique, but such a powerful, when you talk to these families, the capabilities of helping these people. Social service and healthcare, we've talked about that, the communication. We heard yesterday at the social worker level, the ability to share information. And when you hear about Montgomery County, Maryland, and Pennsylvania, and New York, how empowering this is for the caseworkers and for the folks who are so frustrated with limited resources, limited information, but all of a sudden they're empowered by sharing this. Medicaid systems have begun to recognize, you certainly heard West Virginia is an amazing story about how, in some ways, people viewed as a very negative, kind of making the patients take some responsibility for their care and use of services. But when you make HIT part of that, it's a no-brainer. It really makes a lot of sense. You made this really fancy, so it's hard. But obviously, there are lots and lots of problems. And one of the things that is unique about children is that what you do for an infant from a health care, from a social service, from a privacy security is not what it means as the child gets older. And certainly, I'll show you the CHIP language. Actually, Congress recognized that electronic records are not child-focused and don't have the right kind of information. So growth charts, BMI, things like, you know, head circumference, that's not something that exists for adults. So there's a growing recognition now about how important it is to have information that is child-specific. The other thing is pediatricians lag behind. I always have truth in advertising. My brother's a pediatrician, and I use him as my model. It's a small practice. It's a lot like health centers. When I felt I represented health centers, I also felt I was representing the small practices, and I think David feels similarly in his role as a surgeon, although surgeons and pediatricians probably wouldn't think they're in the same strata. But nonetheless, it's small. They don't have IT support desks. They have a person that they're hoping to hang on to who will continue to work in that office. And, you know, I was talking to some of my brother's younger partners, and they're like, we don't even take charge cards yet. So how are we going to have an electronic record? And who are they going to call when something goes wrong? And that's what's so exciting about these rec models and other ideas of reaching out and really helping the primary care providers. We know there are lots of barriers to adoption. I don't need to tell you more about that. And particularly because pediatrics is disproportionately small and solo, they are going to lag behind. And it's going to be very interesting to watch how the incentive payments, the HIT, the new law that was part of ARA, I think for the first time used the word pediatrics and recognized that there were unique challenges to getting pediatricians to become part of HIT adoption. As we've talked about, certainly the pediatric functionality. Why would they buy a product that doesn't help them in terms of children? I should say that all of this information comes from a supplement to Pediatrics about a year ago that was edited by Lisa Simpson and Denise Dougherty at ARC. And so I'm just obviously very briefly going through this, but there is lots and lots of really rich information from the thought leaders in kids and HIT. Privacy for children is just way more complicated, and it changes. And you know, who has control of the information, when it's the parent, when it's the child. There's a lot of issues, and this is a big social service issue in terms of families that are no longer intact. And we actually heard the other day that the non-custodial parent, if they are not the primary insurer, may literally not be able to get access to their own child's information. And how many children today do you know who spend 3 days a week with one parent and 4 days a week with the other parent? And it seems like a no-brainer, but if there are barriers to sharing that information, everybody needs to be able to have that. And you heard a lot yesterday in terms of privacy and sharing of information across systems. But certainly foster children, I mean, it's so sad to think about these kids going from home to home, but not being able to take their information with them and over-immunizing. You want to talk about efficiencies in the healthcare system. It just makes no sense anymore, and it can be fixed. That's what's so exciting here. And we talked about adolescence and information on pregnancy and STDs, and so this just makes things more complicated. And as you heard yesterday, I think some people want to use privacy and security as an excuse for why we can't move forward, but I think you all understand that it cannot be a barrier any longer. But certainly the systems need to understand that different information has to be treated differently, and who is actually going to be able to see that information at what time is somewhat unique to children. Now, some of the positive experiences that are occurring, and I think the CHIP reauthorization is going to allow this to move forward even more rapidly, is using HIT for simplification and sharing information, the one app type of approach, the quick type of, taking information from a school health application and using that to auto-enroll children in Medicaid and things like that. Lots of states are doing innovative things on the application side. Now, this may not be HIT, but it's the same kid again. Quality. You heard a lot about how important quality is, and I won't read through these, but you can see that states are leading the way to understand that sharing of information, bringing information together at the provider level, at the school level, at the personal level, can help you make a big difference in some fundamental ways that these children are being treated, and hopefully we are going to see real measurement in terms of how it's being delivered. We know that many children have complex health conditions, particularly low-income children, and you heard a lot about the medical home and sharing of information. Well, again, let's not over-treat these children, let's not under-treat these children, but let's use health information technology to really share that information. And interestingly, in West Virginia, I had the privilege of visiting one of our health center controlled networks there. And they had a situation where literally when the BMI was calculated on intake, by the time that patient got home, there was a phone call waiting for them saying, congratulations, you've been enrolled in a weight management program. They could opt out, but it was coming full circle very quickly. And that's what we used to talk about in HRSA, is coming full circle. You heard Kevin talk about that. Let's use this information. You've got to figure out the technology, obviously, but this is about the health and well-being and how do we use it to really improve the care. So as I mentioned, Congress recognized in the CHIP reauthorization that HIT was not meeting the needs of children, and so they did create a special program, and there is a process going on right now to hopefully award this fund to really customize and build a system that is specific to children. So, oh boy, this is going to do every one of them. Back when I was in HRSA, and this again is with help from the Nemours and several other foundations, we said, well, let's just get some information out there. And we have a whole series of toolboxes that we've built that are publicly available to all of you. There's a whole series around health centers and primary care. And then this one is just coming up. It's not all up yet, but you can certainly go to this site, around kids and HIT. And the target audiences are providers, policymakers, families. And if you have other ideas of opportunities, we'd like to see one on oral health, for example, let us know. But it's in a question and answer format, so you don't have to read a 500-page manual. It's sort of what is it that I can begin to do. I don't want to leave oral health out of this because, as you heard, health centers are unique because mental health, oral health, often nutrition services, and primary care are sitting in the same, facility. And children and their oral health is just a terrible tragedy in low income. And again, CHIPR recognized that, but there are opportunities. Just imagine if the pediatrician actually knew if the child was going to a dentist, and if the dentist actually knew the child's history, how much power there would be just in that information sharing. So the oral health folks are definitely beginning to recognize how important this is as well. Okay, so here is what we're going to actually do. When I was back in the federal government, I kept saying to the Office of the National Coordinator, like, kids, what about kids? And they said, well, just tell us what to do. So when I left, they actually brought me back to tell them what to do. And there's this thing called the Transform Initiative. And some of you may have heard of the Wounded Warrior Program, where the federal government took the Department of Defense, the Veterans Administration, and Social Security Administration, and actually exchanged information for wounded warriors. Many of you probably know that using health information for disability determination takes months, if not years. They got it down to, I don't know, hours or days, just by sharing that kind of information. So what we want to do is take that power and move it to children. And as a non-IT person, if you think about taking two plugs and having one of those things in the middle that we all used to use, that's what we're going to do here. You're not going to change the programs that are going to get plugged in, but the federal government could potentially help build that connector, and that's why this is all about connecting. So the mission of this new Transform Initiative, and I won't go through the bureaucracy because I can't even explain it, but just think of this as part of what David was talking about yesterday, the Office of the National Coordinator. We want to bring agencies and programs together to solve common business problems and build shared solutions. And what we're going to do here is have a kids focus to that. So we've actually spoken to some of you in the room, but my subgroup is really focusing on looking at children's programs. And I finally was able to convince them that this is not federal. There really is no federal system for children. At best, it's federal dollars going to states. Oftentimes, it's federal dollars bypassing states or federal dollars going through states. And so this gets a lot more complicated, and that's why we're so excited to talk about counties and states and all kinds of programs that we could really help begin to link these systems. And many of you are doing it. Probably every one of you knows about a program that's being linked. Even we talked with Kentucky, which Microsoft gave me, and it was literally somebody who was the state registrar who was tired of all this paper coming in and started sharing information. So it doesn't have to be these lofty, MITA, I love MITA, but these great system things. These can be really simple, practical beginnings. So we want to find some success stories and best practices. We want to identify federal programs that actually are asking each of you for information, but doing it in different ways. How can we begin to streamline some of that? And so this is specifically, I won't read it, but this is our effort around children. We want to be able to improve services for children by sharing information. That's what we've been talking about all day, and you'll have these slides. Again, many of you know about some of these systems. I won't go through them because I have a 1-minute warning. But these are just examples of the kinds of things that we're just beginning in early conversations. We just want to have informal conversations with you. But many of you recognize your own programs right here. And, whoops, that's somebody else. So my contact information is not, it's somewhere maybe. It's on the list, or come and see me. But your assignment is send me an email and tell me who I can be talking to, either you or someone in your state who is doing something around what we've talked about today. And we are hoping, we've had conversations even today, about just starting to bring some of us together, because many of us are focusing on just linking information systems. And if we could start by talking to each other, I think we'll have accomplished a lot. So thank you very much.
We all have worked with citizens, and we know that it's important and great goal. I guess the question is, do we know that the people who care for children and the families of children really want this and see the value of it? And how do each of your programs really engage with the consumer as well as the providers to really, again, see the benefit of this? Because I think one of the things I was talking earlier to Bill about is that when I talk to people nationally or on the Hill or governors or whatnot, they don't inherently see, well, how is this going to benefit the kid? How is this going to benefit the provider? They don't see that. And I think it's implicit. We all kind of know it, but I think that aspect of this is kind of missing in this discussion, because I think we have to be able to sell this concept to people.
I'm going to give a real quick view on this, and it relates to my prior work when I was Secretary of Health and Human Services. So we were doing an awful lot on targeting where all of our resources were going. We had about, I don't know, maybe a $12 billion budget. And we did a common client index and identified 70% of all of the resources of our clients were in only 24 zip codes in the state. And so we identified the top 12 and then partnered with the mayors, right, around the idea of, okay. So I'm in a program in Brockton, Massachusetts, and a caseworker from one of the agencies had stopped by, it was a public health caseworker. The mother was pregnant, and and so this is a newborn type thing. And she had to run next door because she had another child as well. So the caseworker said, well, I'll stay here for a moment while you run next door. While she ran next door, another one of the agencies serving her came to the door, and the caseworker was pregnant and thought, oh, this is, right? So here's the mother when she gets back, and it was ironic because I showed up there at the middle of all this. And the mother said, and by the way, I'm saying this because we heard this all the time. The mother said, I need you guys to start clearing the road between all of these different groups that are dealing with me that don't know they're dealing with me. So I would make the distinction between the Hill. The closer you get to I think if everybody's consumer-centered, the closer you get to the consumer, the more likely you're going to get people saying, yeah. But you got to be for real. I mean, they got to trust you. But I do think if you're close to the consumer and those providers around the consumer and the consumer themselves, I think the consent stuff will work, and I think they want it.
And I think next year we ought to have family voices here,
yeah.
Because they really are, in a lot of ways, the voice for particularly children with special health care needs. But it's such a no-brainer to them that, literally they have this one woman who was the speaker out of Colorado has this picture of herself just surrounded by paper and paper and paper that she has to take with her for her child. Now, that's not every family, but I do think Family Voices is one group that maybe an alliance would be really important, and maybe having them here next year to talk about what it means. The providers, I think, are more of a challenge. I mean, I talked about some of the reasons, but it's got to somehow be in their best interest. I think pediatricians are being overlooked. I think there's tremendous challenge, particularly with pediatrics.
Just one other element. There's another aspect to your question that's about the change process. And we need to do much better jobs at building these use cases of the early adopters that show people the tangible benefits and how this translates. We worked on the project in New York City, and everybody's saying, well, there's no business case for this stuff. There's no business case. So we said, let's go study the business case. And we created 4 case studies of the business case that showed there's a business case. And now all of a sudden people say, oh, there's a great business case. We're going to pursue this. But until they saw the pathway and the tangible results and early adopters that showed how to get it done and then the pathway to get there, then that speeds up the adoption curve.
For clinicians, you need a champion. So you have to have somebody that's already engaged in this, adopted, and understands the benefits of it, because many clinicians don't get it, and they won't get it until they hear it from their colleagues. So it's very important, as I said, to have on-the-ground support, including clinician champions that can show people the tangible benefits from going in this direction. When you talk to clinicians, my own pediatrician for my kids has adopted an EHR and does e-prescribing. He says to me, there's no way I would go back now because my office has become so much more efficient. I know who's been vaccinated. I know, the lab results on all my patients. When somebody's been through the adoption process, they won't go back. But it's a big barrier. It's like a big energy barrier that somebody has to cross to get there. It involves turning your practice off for a few weeks, losing revenue, retraining your staff, putting in all these systems that you don't understand. It's a lot of work to adopt. So it's getting across this big energy barrier. So you've got to bring in people that have already done it and can show why it's a good thing after you've been through the process.
Carol?
And I would add to that, not only do you need someone that's cheerleading for you that's a provider, but you would also have to have those providers involved early and often, and at 5:30 at night or at 6 o'clock at night instead of at noon in your state capital. But I feel compelled, because it's been a couple of hours since I've talked about budgets to anybody, as a Medicaid director, to say that not only do you need the cases of people who have succeeded and lessons learned from those who have failed, but even when we're talking about children, we all love children. We all want to do what's right for children. And, all of our intents are good, but we also need definitive, real, hardcore examples of why this is right for our economies, for our budgets, for our... And it's easily done. It's not anything that can't be done, but don't lose sight with all the, excuse me, I'm going to be blunt like I normally am, but don't lose sight with all the touchy-feely mumbo-jumbo about kids. You need to put it where the rubber meets the road so that we can talk to our legislators, so we can talk to our budget folks and say, here's why we're investing in this.
And I would invite the kind of business case data, if anyone has that, but clearly that is a large part of what our effort is about.
I was just going to say, when I went to visit Cheryl some months ago, the first question she asked me when we took our model was, where's the cost-benefit analysis? How can you actually demonstrate that serving this homeless diabetic woman is actually going to have cost benefits? And so a large part of the work we've been engaged in with Johns Hopkins is to develop the template and the modeling around the cost-benefit analysis. And I think if we can demonstrate that with the interoperability, the service integration, those pieces of work, then we can make the case. Then we can actually go to a policymaker and say, here's why you've got to make the investment in this way. Until then, it makes good intuitive sense to integrate, but it doesn't make business sense to integrate. And I think that's the conversation we need to have.
Yeah. Last question?
Hi, I just wanted to put in a plug. I think our California courts contingent is probably the only representatives of the judicial branch in the room. And I just think, especially with foster children population, not to forget 2 reasons to involve the courts. And I'm not going to get touchy-feely mumbo-jumbo about judges, but two reasons. One is, in California as an example, I mean, we're designing the first statewide case management system for the court system, and the interoperability concepts are very of great interest to us with child welfare and other providers that deal with foster kids. So on the statewide level, we're not unique. There are other states that are doing the same and would have the same interests. On the local level and more personal level, judges can often be great conveners of stakeholders. And you know, the saying goes that when judges call a meeting, people tend to show up. So don't be afraid to approach the courts and gauge their interests if they do have common interests.